Welcome to Dr. Balga's podcast for the Curious Doc. Today is April 11, 2026. This video is on a Nature article published online 3 days ago, 8th April 2026, titled Engineered Immunosuppressive Dendritic Cells Protect Against Cardiac Remodeling. Heart failure is driven by inflammation, cardiac fibrosis, and immune dysregulation. No therapy directly targets immune-driven remodeling. Dendritic cells enable antigen-specific immune tolerance. Engineered immunosuppressive dendritic cells were developed by these authors because they are widely distributed, residing in peripheral tissues exposed to the environment, such as the skin, the lungs, and the gut, circulating in blood and trafficking to secondary lymphoid organs, such as lymph nodes and spleen, where they present antigen to T cells. They chose the dendritic cells because they sit at the interface of innate and adaptive immunity, enabling antigen-specific localized immune tolerance via TREG induction and checkpoint signaling, a uniquely suited platform to reprogram inflammation driving cardiac fibrosis without systemic immunosuppression. They use mouse models of myocardial infarction, ischemia reperfusion, TAC, and non-human primates, targeting via fibroblast activation protein for injured myocardium. The intervention they used was PD-L1, IL-10, CTLA-4 Ig expressing dendritic cells. They combined these cells create a synergistic multi-phase immunoregulatory program targeting early T-cell inhibition, late checkpoint suppression, and broad anti-inflammatory signaling. This synergistic multi-phase immunoregulatory program durably induces immune tolerance and limits cardiac remodeling. The mechanism studied includes single-cell RNA-seq and T-cell receptor sequencing. Endpoints included cardiac fibrosis, cardiac perfusion, contractility, and immune activation. Follow-up up to 12 weeks in murine models. What did they find? Marked reduction in cardiac fibrosis with histologic and molecular markers, p-value 0.0001, improved ejection fraction and fractional shortening, increased angiogenesis and perfusion, TREG expansion and suppression of inflammatory pathways, blocking PD-L1, CTLA-4, and IL-10 reversed benefits. FAP-targeting was required for therapeutic efficacy. This is fibroblast activated protein targeting was required for therapeutic efficacy. Non-human primates showed improved function without toxicity. Limitations of the study, preclinical design, and scalability concerns. Key takeaway: immune reprogramming can reverse cardiac remodeling. Clinical pearls: inflammation drives remodeling. Immune checkpoints are therapeutic targets. Cell therapy may transform heart failure. Localized therapy avoids systemic toxicity. The future: hemodynamics to immunology shift, so-called cardio-immunology program for heart failure. Podcast brought to you by masterbedfacts.com. This podcast is for physicians and healthcare providers. If you enjoyed this video, please like, subscribe, and forward to your friends.